Morning, sir.
Good morning, sir.
That's it.
Good morning, sir. Today's my journal is about result of 331 two-stage exchanges for periprosthetic joint infection following total hip replacement, showing low reinfection and mechanical failure rates at 10 years of follow-up. It is a retrospective study done in Minnesota, published in March 2025, sir. The aims are to evaluate the result of Bailey.
Berry, Daniel Berry. He is the main person.
Okay.
From Mayo.
Aims and objectives. Aim is to evaluate the result of two-stage procedure following total hip replacement in a large cohort of patients with no prior treatment for periprosthetic joint infection, with a special focus on cumulative instance of reinfection and aseptic mechanical failure over a long-term follow-up. Materials and methods. Retrospective study done in patients treated with total hip replacement who developed periprosthetic joint infection and underwent two-stage exchange procedure between 1993 and 2021. Inclusion criteria: more than 18 years of age and had entire two-stage procedures performed at the institution. And exclusion criteria: if they had any prior treatment to the infection. Out of 1,214 hips which have underwent two-stage procedure during the study period, 883 hips were excluded because they had underwent prior treatment for periprosthetic joint infection, and the remaining cohort included 331 hips, and of these 15 hips were in patients who died prior to 2 years follow-up, 35 hips had less than 2 years follow-up, 30 hips had revision within 2 years, and for the remaining 251 hips, mean duration of follow-up is 8 years from the time of reimplantation. Mean age at the time of reimplantation was 66 years, and females contributed to 38% of the cohort with a mean BMI of 30. And diagnosis of periprosthetic joint infection was based on 2011 Musculoskeletal Infection Society criteria, which was retrospectively applied to the cases done prior to 2011. Patient charts were reviewed for physical examination, serological markers, synovial fluid analysis, microbiological and intraoperative findings. This is the criteria. This is the musculoskeletal infection and society criteria, sir. Major criteria being 2 positive cultures, are a sinus tract communicating with the joint. Minor criteria are elevated inflammatory markers, elevated synovial fluid WBC, elevated synovial fluid neutrophil cells. Positive single culture are a positive histological analysis of tissue. At least one major criteria or 3 out of 5 minor criteria were satisfied in 276 hips, and the most common organism cultured was coagulase negative staphylococcus. In the first step of two-stage extend protocol, all patients underwent removal of implants, debridement, and insertion of antibiotic impregnated spacer. These spacers are of 2 types: static non-articulating spacer done in 195 hips, consists of a hand-molded cement spacer in acetabulum and a cement dowel for femoral canal. Static spacers were done in cases where there is less bone loss and with adequate soft tissue envelope, whereas articulating spacers containing of a femoral stem coated with antibiotic cement and high molecular weight polyethylene acetabular component was cemented into acetabular defect. With the help of articulating spacers, post-op patient was allowed partial weight bearing on the affected limb. This is the procedure by which articulating spacers were placed. Initially, the mold is filled with the antibiotic loaded cement, then femoral component is placed in the mold and is allowed to harden. Another mix of cement is placed in the debrided acetabulum, followed by fixation of polyethylene liner. Then the femoral component is removed and inserted into femoral canal. Then adequate size head is impacted into the implant and hip is reduced. Cement was used with combinations of vancomycin in 300 hips, along with gentamicin in 219, tobramycin in 78, meropenem in 1 hip, amphotericin B in 27. Antibiotic type and dose was based on susceptibility profile of infecting organism, and in cases where microorganism was not identified, combination of vancomycin and gentamicin was used. After placement of a spacer, patient was managed with parenteral antibiotics for a mean of 6 weeks. The timing of reimplantation was based on sequential normalization of inflammatory markers during antibiotic treatment and antibiotic holiday, in addition to patient's clearance for surgery. The mean time for cessation of antibiotics to reimplantation was 10 weeks. However, it extended up to 120 weeks in case of high-risk cases and polymicrobial resistance. Of these 330 hips, in 34 hips, repeat debridement and spacer exchange was necessary due to following reasons. That is postoperative hematoma evacuation, gross purulence at planned reimplantation, persistently increased inflammatory markers, and addition of amphotericin B to spacers after the culture showed positive fungal infection. The surgical approach, irrigation and debridement technique, as well as implant selection, varied according to the surgeon preference. Cementless femoral fixation was done in 79%, while cemented in 21%. All the 3 established components were uncemented. Then patients were managed with 6 months of chronic antibiotics suppression after implantation in high-risk cases. Clinical follow-up and radiological follow-up were completed first, second, 5th years and every 5 years thereafter. Harris HIP score were analyzed for all patients with a minimum of 2-year follow-up. Revision, reinfection, reoperation and complication was analyzed as time of reimplantation to event outcomes. Cumulative incidence of all the above were calculated using date of reimplantation as a starting point and the event of interest or last known follow-up as an endpoint, with death is considered as a competing risk. Incidence of reinfection was 7% at 1 year and 11% at 5 and 10 years. 33 reinfections were seen within 5 years of implantation because of following risk factors, which include BMI of more than 30 and need for spacer exchange prior to reimplantation and use of chronic antibiotic suppression. Cumulative incidence of any revision was 13% at 5 years and at 10 years, whereas incidence of aseptic revision was 3% at 1 year, 7% at 5 and 8% at 10 years. Most common indications for aseptic revisions are dislocation, acetabular component aseptic loosening, femoral component aseptic loosening and mechanical failure. Here we can see the incidence of revision at 10 years follow-up is at 13%, whereas aseptic revision incidence at 10 years is at 8%. Cumulative incidence of dislocation was 11% at 10 years, which contributed to 33 cases. Almost 15% of cases required revision surgeries. Apart from reinfection, revision, reoperation, dislocation, other complications were also observed, which were postoperative periprosthetic fracture, femoral fracture, intraoperative femoral fracture, non-union of extended trochanteric osteotomy, spacer dislocation, psoas tendinitis, and heterotopic ossification. The mean Harris HIP score improved from 54 to 75 at 10 years, and among cases which had both pre-op and post-op scores, scores improved from 56 to 82 at 2 years and 50 to 81 at 10 years. Although one-stage exchange arthroplasty has gained attention because second surgery was not necessary and cost to healthcare system was reduced, these series are limited by short-term follow-up, and they only select cases which include healthy patients, susceptible organisms, and minimal bone loss. But in this series of 330 patients who underwent 2-stage exchange arthroplasty, they were largely successful in treating periprosthetic joint infection with a 10-year cumulative incidence of recurrence of only 11%. And exclusion of patients with prior treatment of infection highly contributed to high success rate. Elevated BMI was also found to be a significant risk factor for reinfection, which is consistent with prior literature. Use of antibiotic suppression for more than 6 months was associated with reinfection, and concerns remain regarding microorganism resistance. In contrast to low incidence of mechanical failure, dislocation rates remain high. One-stage exchange arthroplasty is a single surgical intervention with reduced hospitalization and rehabilitation time, but also carries higher risk of persistent infection if the selection criteria is not strictly followed. In 1.5 stage, where functional articulating hip antibiotic spacer is placed with the intention to retain it for longer time, It allows ambulation and also avoid morbidity associated with second stage, but have a disadvantages of spacer wear and dislocation, and may require second surgery procedure if infection recurs. But this two-stage exchange arthroplasty can be done in case of resistant polymicrobial cases with severe soft tissue compromise and severe bone loss, with higher infection eradication rates, and allows for prolonged local antibiotic delivery. The disadvantages being longer hospitalization and rehabilitation and potential for patient being drop out between the stages. Limitations of this study are, it is a retrospective study, so there is a potential to introduce selection bias. While their institution has general guidelines for medical and surgical management of infection, there was no standardized protocol, and the surgeon preferences dictated the spacer construction, timing to reimplantation and reconstruction plan. And this study describes the experience of a single high-volume tertiary referral institution, and these results may not be generalized to all practices. Although two-stage exchange is a gold standard treatment for chronic periprosthetic joint infection with lower reinfection rates and higher functional outcome, they also carry drawbacks such as prolonged disability, increased healthcare cost, higher morbidity rates between stages, and also lack of clear metrics for the optimal timing of reimplantation often exacerbates the risk of treatment failure.
Very good. Who advised to whom did you consult the paper? Sridhar. I think that was very good because see the difference between infected implant and prosthesis is different. In case of infected implant, you can take it out once fracture is united, and the chances of healing are significantly high. Whereas in a prosthetic joint infection, you can't take it and leave the patient well alone. You have to put the implant back, otherwise significant disability. So what do you think of the, did they give useful information?
Yes.
What is 1.5 stage revision?
Where functional articulating antibiotic spacer is placed so that patient can walk post-op.
So some of them can be left alone. That led single stage revision.
Yes.
Because I know it's, I think probably most of you will face these problems because more and more joint replacements being done, both hips and knees, and more infections will come to your practice. So you should know how to deal with. So it is important that, of course, two stage is a gold standard, but single stage where patient is healthy,
Yes.
not much of bone loss, and you have to know the organism and its antibiotics, because these people are put to antibiotics maybe up to 3 months, 6 months sometimes. So they should be able to withstand, and toxicity of the antibiotic should be low so that we can give prolonged antibiotics. Okay, so what is the critical, what is that, the discussion you are not doing? They made a good paper. It's published in, forgotten which? JBJS, American. Published, of course, their own journal, but published. I think their analysis is good. They are being very honest, because the retrospective is always biased, isn't it? Selection bias. Okay. Anything else? Anybody? Sridhar?
So they have not classified which patients they have taken into two stages, sir. So some patients were even available for a single stage arthroplasty also, so they have not put any discretion. Second, there is also surgeon preference for making an articulating spacer or a non-articulating. So that could not be classified. Probably any prospect guidelines. Yes.
Number is significant number, quite large number, and good follow-up. I think Daniel Berry is one of the leading surgeon from. He does a lot of revisions, and this was criteria. You said 2011. There is one more 2018, and recently there's 2025 is going to come out. The criteria, because the problem with joint infection (PJI) is difficult to diagnose. Acute infections we can diagnose easily, but chronic infections very difficult sometimes because low-grade infection difficult to isolate the organism, and most of the investigations may not be positive. So you have to have combination of criteria because it's unlike any other infection, joint infection, difficult to diagnose. That's why most of the cases are delayed in getting treatment. But I think that's at the 1.51 where we can use a shorter, means a size, smaller size stem as well as cup, more cement, so that we can leave them, elderly people, leave them forever, so they may not need revision.
And infection is not a localized infection. You are talking about the THR. Doesn't mean that it's a THR infection. It is a systemic. So all points are important. Sir, yeah. It is a systemic focus also. You have to do.
Yeah, but THR generally, and did you say, of course they will say, but classification, they didn't classify how many were immediate, how many were acute, how many were subacute, how many chronic.
No,
They did
they
not
didn't
classify because probably they did not have the data.
Yes.
Do you know anybody knows classification? In general, whose classification? Can be acute, immediate post-op within 2 weeks or within 4 weeks. That's an immediate post-operative one. Subacute. Subacute means after 1-2 years they present with septicemia, acute infection. Acute septicemia might end up in ICU. Chronic one is persistent chronic infection.
And even in our series, you said 1 year, 5 years, and 10 years. So why there's a difference?
What was the question?
No. Even in even in presentations, you said revisions. You said in follow-ups, you said some of the cases in 1 year,
No,
some of the cases in 5 years, some of the cases beyond 10 years. Can you show the slide, please, if you don't mind? Results.
Revision, that's it. Revision rate. So on the whole, overall, reinfection, because it's not 100% successful. Treating infection is always, there is a 10% recurrence rate. That means if you do 10 cases, 1 case will have reinfection. That's a significant number. Okay? That's good, very good, well done. X-rays done? All X-rays.
Our point is well taken. That's all important.
No, ఆవలిస్తుంటే
It's a very good presentation by
నేను రావాలి సార్ చెప్తాను నేను అదేం చదవలేకపోతున్నాను.
obviously Sushma's presentation.
Nice.